Rick Dutton, thanks so much for coming to Sydney. A long way you've made, a great journey. I guess I am interested in your journey in particular, Rick, from a background of working in the United States' largest trauma centre to now going into a major reformative health change in terms of health administration. How have you found that journey?
It's been interesting. I think most academic anesthesiologists, engaged anesthesiologists, this is how they start, with clinical problem, one patient at a time, the person in front of you, then groups of patients, systems, a disease, in my case trauma, and then thinking about the system as a whole. I think that's actually a very natural evolution. That's how a lot of us do that.
I loved your talk at the trainee lunch session, or the trainee session, should I say, about the management of the airway in trauma, and your pedigree in being able to talk about that is unrivaled, having worked in such an institution. You very much concentrated on keeping it simple, get the basics right, don't overthink it, just get the tube in. I love that approach. I think all our trainees should have that approach.
Well, that's sometimes we miss that very pragmatic thought, and that's one of the reasons that talk is the way it is. I mean, there's hundreds of airway talks out there, all very focused on the new toy or the new trick or the new technology, but sometimes we miss the forest for the trees there.
I totally agree with you. That's what I liked about it. You put it all in perspective, your risk rating. Look, can I ask you, you just gave a fantastic talk there about pay for performance. You made a comment that if a practice in healthcare does not reduce morbidity or improve quality of life or return people to significant improvement in their function, we should question its value. What is, of those three sort of metrics that you talked about, what does pay for performance, how does that fit in? How does that qualify?
Well, broadly it makes sense. As I said at the beginning, we should buy good value healthcare, just like you want to buy, fresh bananas and a good car. But the devil's in the details. And it's very easy, and it has happened in the United States unquestionably, for the process to overwhelm the results. So we want to buy high-valued healthcare, and that makes sense. It's something the consumer wants, the patient wants, good quality care. But as you attempt to force that through incentives, it gets very complicated very quickly.
Do you, in Australia and New Zealand, we're instinctively, I guess, a little bit cynical about bureaucracy and government. I mean, are they motivated by? Do you think they're motivated by genuinely wanting quality improvement, or are they just motivated about just restricting the ballooning crisis in healthcare dollar escalation, healthcare costs?
Some of both. Most of the people I work with in the federal government, Centers for Medicare and Medicaid Services, for example, CMS, who drive a lot of what I was talking about, really believe they're trying to make healthcare better. And there is no question that measuring performance is a pathway to improving healthcare. And you've heard that in a bunch of different quality talks here, is you have to measure it in order to make it better. Where the problem comes is when you start putting money on that, then it gets very complicated, and that's when the gamesmanship arises. So on the one hand, it's the right direction. We should measure outcomes in healthcare. We should work to improve them. But we should do it because we want to, not because somebody's making us do it. So the idea of intrinsic motivation, professionalism, versus the extrinsic motivation. And it's that extrinsic piece where the unintended consequences arise.
Sure, and I did like your view that we need to be in the game. We need to be in the game from the beginning, and that's our way in health to influence the argument.
Again, very pragmatically. Just if we don't want to get screwed, we have to participate in the process. And the sooner we do it, the more aggressively we do that, the more we can control the process. The saying in the U.S., if you're not at the table, you're on the menu. And we want to be the ones who establish these are the measures that apply to anesthesia. We want to say that. We don't want somebody else to tell us that.
Oh.
And we want to say this is how it should be measured, how it should be incentivized, how it should be done. And I guess it's making the best of a bad deal. It's coming. We have to do it. You know, public measurement is going to be required. Let's make it as sensible as we can.
One final question. What are your thoughts on, I guess, you know, this is partly about identifying poorly performing practitioners and poorly performing practices. How do we deal with poorly performing practitioners? We're finding it very difficult. In this context, it's all about the remuneration being removed and it's incentivisation in that regard. Do you have any thoughts about other ways to, I guess, improving our performance and also to managing the poorly performing practitioner?
Sure. First of all, I'm a fan of Deming. It's not people, it's systems.
Yeah.
And truly poorly performing doctors are extremely rare.
Yes.
They're usually poorly performing in many dimensions, and you don't need complex medical systems to find them. They become apparent very rapidly and are typically eliminated from most groups very rapidly, the true bad apple.
Yeah.
But that's extremely rare.
Sure.
Most of what benefits society, most of what we need to do is improve our systems to make them communicate better, to make them better coordinated. That's where the real value is going to be. And that's the advantage of the big data. If you can identify, here's a system that's not as good, or to put a positive spin on it, and one of the things I do in my group all the time is let's find the bright spot.
Yeah.
So I know exactly which of my practices has the highest patient satisfaction scores, for example, and I'm putting a lot of effort into figuring out why that is and exporting it to everybody else.
Yeah. Thanks again for your time and really enjoying your talks. Thank you.
Oh, sure. Thank you.
Thank you.